Morning, Steve. How are you? Good. Ready? All set? Okay. So good morning. Today we're announcing that we secured an order with iHealth Labs to supply the Commonwealth with 26 million rapid antigen tests over the next 3 months. We expect to receive rolling shipments from this contract beginning this week. The timing and size of the shipments will vary a bit depending on international shipping and production variables. The tests will be prioritized to support K-12 education and childcare. We'll provide more details on how we plan to distribute these tests to these entities shortly. As we've said many times over the course of the past few months, rapid tests are convenient and efficient. They can be completed at home with results in just 15 minutes. They are also accurate in detecting when someone is about to infect others, and that's why our administration is prioritizing securing these tests. The 26 million tests come on top of the 2.1 million rapid tests that we gave to 102 cities and towns before the holidays, and the 200,000 tests we distributed to educators before they came back after the winter break. We also organized several statewide contracts that every city and town can tap into for municipalities to buy rapid tests in bulk on their own, and several have. We encourage other municipalities to take advantage of this resource as well. Today, the Department of Public Health also released a new public health advisory with respect to advising the public around when to get a COVID test. This has been the subject of much debate over the course of the past few weeks. And DPH felt it would be helpful to create some clarity around this particular issue, given the amount of testing that's going on generally. DPH advises residents to get a COVID test under 2 key scenarios. 1, if they're exhibiting COVID-19 symptoms, and 2, if they're a confirmed close contact of someone who has COVID-19 in line with DPH's updated isolation and quarantine guidelines. Remember, with the new quarantine guidelines, DPH recommends but doesn't require that all exposed individuals get a test 5 days after exposure. DPH's advisory also makes clear that rapid tests in most situations are a very good alternative to PCR tests. PCR tests are the ones frequently used at drive-through and on-site testing facilities. They can take up to 24 to 72 hours to produce results, while rapid tests, as I said before, can turn results around in 15 minutes. Rapid tests are highly accurate at determining when an individual is at their most transmissible period of COVID-19, and they have many advantages to PCR testing, especially at this point in the pandemic. Because of this, DPH advises that a positive COVID-19 rapid antigen test does not need to be confirmed with a PCR test. We've heard from many of our testing sites that they're seeing increasing volumes of people who are seeking PCR tests specifically because their employer or their school or their child care center is requiring a PCR test to return from isolation. To be clear, DPH doesn't recommend that employers or schools or child care providers require a test to return from isolation after having COVID. However, if they do require testing, DPH recommends they do not require a PCR test. We know that many testing sites have seen increased volumes over the past few weeks as we deal with this current surge. People seeking tests should remember that DPH advises that you should only get a test if you're symptomatic or a confirmed close contact. Vaccines and boosters work. The data on this is unassailable at this point in time. They've been a game changer with respect to this pandemic. Getting vaccinated and boosted remains your best possible protection from getting really sick. Testing has a specific use in combination with vaccines, and we hope that DPH's advisory will help people navigate this issue. Rapid tests are great tools. And with the deal to secure 26 million additional tests, it will be enormously helpful to our effort here in Massachusetts. But again, vaccinations remain our best tool. Doctors, nurses, and every medical institution are in agreement on this. The vaccines are safe and effective for adults and kids. Massachusetts continues to lead the nation in getting our residents vaccinated, with over 5.1 million residents fully vaccinated. And today, on average, Massachusetts is still administering between 40 and 50,000 shots a day. There is still steady demand out there. Today, I also plan to activate 500 members of the Massachusetts National Guard to continue to add support to our healthcare system, driven by staffing issues associated with Omicron. These members are on top of the 500 we activated earlier this month. These Guardsmen and women will join the ranks of soldiers already assisting our medical facilities. There's no question, at this point in time, that staffing remains an enormous challenge for many of these providers. This activation will alleviate some of the pressure in those places. It's important to remember, while there are many Guard members with medical training, not all of them have medical training. Many of them have other kinds of training. And for many of the Guard members with medical training, when they're not serving, they're working in a hospital or a long-term care facility or some other healthcare organization. So these deployments require time and attention and training before they can get to work if they don't come from the healthcare community to begin with. I can't tell you how grateful we are to the men and women of the Guard for stepping up once again to support the Commonwealth's response to COVID-19. Massachusetts, like virtually every other state in the country, has seen a significant rise in COVID cases over the past several weeks. We do have the tools here in Massachusetts, the most prominent among them, vaccinations, to protect ourselves. DPH data shows that breakthrough infections in vaccinated individuals very rarely result in serious illness. If you haven't gotten a vaccination or a booster, please book an appointment and get one now. We've opened 5 additional state-sponsored vaccine and booster sites over the course of the past several weeks, and each site has added hundreds of doses in capacity every day. The new sites are in some of the hardest-hit communities in the Commonwealth: Boston, Lynn, and Taunton. And parents, if you have questions, you should know that pediatricians across the country are vaccinating their own kids. And if you do have questions, you should talk to your doctor, your child's doctor, or a healthcare professional. Questions?
How long do you think the 26 million tests will last? Once you put them in the field, are you going to do another 26 million in February, or any guess how long it's going to take?
So, remember, the 26 million tests are expected to arrive on sort of a regular basis over the course of the next 90 days. So we expect we will see a regular supply available to us throughout January, February, and most of March. Given some of the issues that everybody's been dealing with associated with supply chains, what I would say is we expect we will have we will have tests available to be distributed, and our 2 key priorities here are going to be K through 12 and child care on a pretty regular basis over that period of time. But I'm not giving an exact number today because there's going to be a range here, and I think some of it will be a little lumpy as it comes in. But I do expect we'll continue to get tests through March.
Does that mean the people who are in K through 12 early child care won't have access to the test? Will there be some for just your average people, or is this specifically for the categories you mentioned?
I think what I guess I would say is, given the challenges everybody's had with the supply chain issues here, what I would say today is the goal right away is to support K through 12 and child care. As most people know, we put $2 million out before the holidays to cities and towns, especially those that have been hardest hit by COVID and had the highest poverty populations. We will play this one a little bit based on how the supply arrives as it gets distributed. But the idea that we would like to be able to make them available more broadly, if we can, is certainly something that's on our radar.
So then my question is, there are a lot of people who can't afford these tests to buy them, or they can't buy them. So these lines at these testing sites are just getting longer. It's colder, as we know. So do you have any plans to expand the amount of testing sites or to help with those people who are still lining up for those PCRs then?
Well, first of all, there are a lot of people, we've heard this anecdotally from many of the folks who run the sites, that a lot of the people who are showing up there every single time are showing up because they need it for their employer, they need it for school, they need it for childcare. Part of the reason for the DPH order today is to make clear that you don't need a PCR test. We do not believe, DPH does not believe, by the way, the CDC and the federal government don't believe either, that you need a PCR test to go back to work, to back to school, or back to childcare. We believe the antigen tests, which are enormously accurate, especially on the back end of contagion, are a perfectly suitable solution. And I think one of the things we're trying to make clear here today, both to individuals and to employers generally, is the PCR test is appropriate in certain circumstances, but these rapid tests can be used in many circumstances as a legitimate alternative.
So no plans to open more testing sites?
We have about as much testing capacity open as on a per capita basis as you'll find anywhere in America.
How is the strain on the healthcare system here in Massachusetts? Are we at the breaking point at this point, or are they holding out?
Look, I think the past almost 21 months now, for the healthcare system generally, has been profoundly challenging and difficult. And the load that the folks who work in healthcare, and I'm talking healthcare broadly, from literally, the folks who are in the ambulance business to the folks who are in the clinic business to the folks who are in the community health center business to the folks who are in the assisted living business, the long-term care space, the hospitals. They have carried an enormous load for everybody, not just here in Massachusetts, but around the country for the past 2 years. And the thing you hear over and over again from the people you talk to is that this is exhausting and has been exhausting. You combine that with the fact that at this point in time on the hospital side, because of the staffing shortages they're dealing with, which by the way are not much different than the staffing shortages many people are dealing with, there's about 700 beds that are currently not staffed that at this time last year were available. That creates additional challenges for them, which is why the Guard has been such an asset to the folks in the hospital settings, doing many of the jobs, not so much the clinical ones, because we've tried to make sure we leave the clinical people in their civilian job doing their civilian work. But they've been assisting and supporting a whole variety of other activities that go on around the hospital system and the healthcare community to support the work of those who are very much on the front lines. But I think both the ebb and flow of all of this, as well as the duration of it for the healthcare community, has been enormously difficult and challenging. And they've played way above what I think anybody's reasonable set of expectations could have imagined.
And Governor, could you shed some more light on the distribution of the tests when they get in? Do schools have to reach out and apply, or how is it determined which districts get X number of tests?
Well, first of all, we have been testing in schools since last spring. We were the only state in the country to set up a pooled testing program, which admittedly is a 24-hour turnaround program for teachers and staff and kids last April. And by the time we got to this fall, basically every school district in Massachusetts, one way or another, was participating in some piece of that pooled testing program, or they were participating in the Test and Stay program, which has probably saved 450,000 in-person school days, or they were participating in one of the other testing programs we made available. So point number one, there's already a lot of back and forth around testing going on every single day between the Commonwealth, DESE, and school districts. And I think what we will try to do here is to make sure that we incorporate rapid tests into that delivery mechanism in a way that supports and amplifies that existing delivery system we already have in place, as opposed to setting up something that's completely new and different.
So the state will send them and sort of weave it into the current program, but you guys determine exactly which districts or schools get X number?
Yeah, but keep in mind, we have about 7 or 8 months worth of pretty solid data between last spring and this fall on what the traffic looks like around testing generally in most of these schools.
Last question.
Do you want to take a swing at that particular question?
Good morning. Good morning, everyone. So as we are, as the governor said, as we plan for these 26 million tests over the course of coming in over the next 3 months, we want to ensure that we have sufficient rapid antigen tests for both schools through the school semester through June, as well as for early education care. So we're planning to ensure that we have sufficient supply to keep schools open through the school calendar, if you would, as well as for early education and care. That's in terms of the modeling that we're doing at this point.
How difficult has it been for the state to try and secure these tests? I know we had some districts after winter break chose not to open because they said they didn't feel comfortable opening up without all the tests that they said that they needed. What's it been like from the state's perspective trying to secure them and be able to roll them out?
So I think that we were very pleased in, seems like a lifetime ago, in December, when we were able to secure the 2.1 million with iHealth. We have a contract now with iHealth and added to it for the 26 million on a rolling basis. And again, I think we would just caution everyone, given the supply chain issues that we've experienced throughout this pandemic, that we are working with iHealth to ensure the delivery over the course of 3 months, and we need to plan this on a rolling basis. But our priorities, as the governor said, is to ensure that K through 12, as well as early education care, has supplies they need so we can keep them open.
Hey, can I take this question just up one level? Some of us have been on the record for a really long time that the U.S. has been a laggard on both approving and creating a program model around rapid tests. Last summer, you could go pretty much to any Western European, even Eastern European country and find hundreds of companies that have been authorized to develop, manufacture, and distribute rapid tests all over the place. And they were available, generally speaking, for $1. At that point in time, there were a handful, literally a handful of rapid test manufacturers who had been approved to manufacture and distribute rapid tests in the U.S. In fact, for a long time, there was basically one. And at this point in time, there's still only a handful. It's now basically 2 handfuls. It's somewhere between 10 and 15 companies that have been approved. And that all by itself, during a period like this, creates challenges associated with accessing tests. And I think part of the reason we were able to secure this significant order is because we started chasing this manufacturer back in around Thanksgiving. And we now have a relationship with them, and we believe that that relationship is solid, but they then have to deal with some of the other issues associated with the fact that we don't have as mature a delivery and distribution system as they have in many other Western democracies.
Governor, growing calls for a return, or at least an option to do remote learning, as some districts are shutting down for days, using snow days and missing out on school. Any change of heart on that, allowing remote to be an option for these schools instead of closing entirely?
So I think the big lesson we learned from last year was that, and by the way, every respected healthcare organization and public health entity that I know of in the U.S. would tell you that school is not only safe, it's healthy for kids. And I think the most important thing we need to do with these tests and with other tools is make it possible for people to continue to be in school. With respect to remote learning, I think for the vast majority of kids, based on all the data that's out there about learning loss and everything else, and not to mention the social isolation, the loss of developmental sort of community development and all the rest for kids, it was a very bad year. And we know that school districts have professional development days. They have snow days. They have other days that they build into that 180-day of school calendar at the start of every year. And if people choose to use some of those days during this period of time for something other than in-person learning, that's their call. But they do have a reservoir of days that are available to them for things other than in-person learning. But our view is we should be doing everything we can to make sure that kids get that 180 days of in-person learning, because it's critically important, not just to their educational development, but to their development period. And that's been demonstrated by what happened over the course of the past 2 years.
So when Boston Mayor Michelle Wu says, you know what, we're forced to do some remote here, we're preparing remote plans and we'll worry about the state giving us credit later, are you telling me they won't get credit?
I'm saying everybody owes the kids of the Commonwealth 180 days of in-person learning.
Last question.
Yesterday, the state rolled out the electronic vaccine
Card.
I know it's early, but I was able to get my QR code right away before 2 o'clock. Last night, my wife couldn't get hers. How's the system going?
So the first thing I would say is everybody needs to understand that this may have seemed like a small issue at the time, but however it was you identified yourself when you got your vaccine, that's the way the system responds, because that's the way you're located in the system. So if you put in your cell phone as your primary point of contact, or you put in your email as your primary point of contact, or if you used your full name, not your nickname. So if you used Stephen with a PH instead of Steve, okay? It's in there based on your primary way, you know, line by line, that you actually, you put it in when you got your first vaccine. And I had several people reach out to me last night and say, you know, I can't get in. And I said, well, do you remember how you actually signed into the vaccine program when you got your first vaccine? Well, I think I put my cell phone in. Well, then try that. And they tried it and it worked. There is a 211 number that had no waiting time on it yesterday that's available to people if they're struggling to figure out how to access their data.
And
But
there's an online form.
and there's an online form too. But we had hundreds of thousands of hits to the thing last night, and the vast majority of the feedback we got was more like yours. It was pretty positive.
Thanks, everyone.
Two quick questions. One, the increase of the National Guard members, is that because there's an increase in staffing shortages, or is it related to, you know, back a few months ago? And two, when it comes to hospitalizations for COVID, the numbers that the state releases, are those numbers distinguished from people who are being treated for COVID, and or those who have a broken leg, they got tested, and they also happen to have COVID?
Okay, so I'll answer the second one first. We started talking to the hospitals about 3 weeks or a month ago, somewhere around there, about this issue around incidental COVID positive tests in hospitals, because it was starting to show up anecdotally, particularly in comments that were coming from clinicians in emergency rooms who were saying that they had people who tested positive for COVID as part of the entry protocol, but really weren't there because they had COVID. They were there because they had appendicitis or they broke their leg or something else. And then over the course of several weeks of conversation, we worked with the hospital. Then the question becomes, how do you come up with a mechanism to actually distinguish this? And we came up with a plan to do so. And Monday, yesterday, was the first day in which the hospitals under this new framework are going to be collecting both COVID incidental data as well as actual COVID as primary rationale for hospitalization and admission. And so the data that comes out at the end of this week will include both, the total number and then the number of incidentals. And obviously you can figure out how many are actually there because they have COVID. This is something that's now being done in a lot of different states for exactly this reason. I'm sure a lot of people were getting some of the same incremental information from people in the healthcare community generally. New York published their first round of data on this over the weekend, and it showed that about, I think around 40% of their COVID hospitalizations were incidental hospitalizations. New Jersey, the number was about the same place. I think you're going to see most states move in this direction. What was the first question?
The National Guard, was that an
Oh.
increase in response to like holidays and recent, upping and testing?
The Guard, the call out on the Guard is basically to continue to amplify our ability to support healthcare organizations. I mean, you're going to see them deployed primarily in what I would describe as support and technical roles in our hospitals, in our ambulatory centers. They're going to be working in the healthcare space.
Thanks, everyone.
Thanks, folks.